I'm Rebecca Kirch from the National Patient Advocate Foundation, and we welcome you all this afternoon to this partnership series brought to you by the National Patient Advocate Foundation, the Association of Community Cancer Centers, the Community Oncology Alliance, and the Oncology Nursing Society. We're pleased to feature communication skills development as today's topic, and I have the honor of introducing our webinar faculty, Dr. Anthony Bach. Dr. Bach is Professor of Medicine at the University of Washington and Fred Hutchinson Cancer Center, and he's the co-director of the UW Palliative Care Center for Excellence. His career has focused on improving patient-physician communication, and his work has been supported by the National Cancer Institute, Arthur Vining Davis Foundation, Robert Wood Johnson Foundation, among many others. With Robert Arnold and James Tulsky, Dr. Bach authored Mastering Communication with Seriously Ill Patients, Balancing Honesty with Empathy and Hope. And as co-founder of Vital Talk, which you'll hear about in this webinar, Dr. Bach and colleagues have developed a treasure trove of practical, hands-on resources and training offerings that are dedicated to sharpening clinicians' communication skills, and they help build both patient and family trust, as well as promoting professional resilience. After Dr. Bach's presentation, we've reserved time for your questions. There's a chat box on the lower right of your screen that you can click on to enter your questions at any time, and we reserve time at the end, and my colleague Peterson will be moderating those questions. Immediately following the webinar as well, we urge you to please respond to 4 brief survey questions that will appear to help inform our follow-up activities to support all of you. Before I turn the webinar to Dr. Bach, we'd like to introduce 2 brief poll questions for our participants to answer to set the stage for this session and provide real-time response information from all of you. On our first question, please click on the answer to the question, can clinicians be trained to communicate more skillfully? Give you just a couple of seconds to click in. Yep. Okay, we're pulling up the results. A resounding number responded yes. Indeed, clinicians can be trained to communicate more successfully and or definitely. Question 2 takes us to the next step. Does better communication change what happens with patients? Please click on your response. Thank you for your responses. Again, folks are responding favorably that yes and definitely. Better communication does change what happens with patients. So now we will hear from Dr. Bach, some details about exactly how this happens. Tony, the floor is yours. Okay. Tony, it seems like we're having a challenge changing you to presenter. I'm sorry, so if you ask, we can advance the slides.
Oh, okay. Why don't you just advance the slides?
Let's try to resolve that, but for now.
Don't worry. You know what? You could just it'll work fine if you advance the slides. Thank you. Well, so Rebecca, thank you very much for this opportunity to present to this group, close to my own heart since I'm a medical oncologist in my initial training. If you flip to that first slide, which says, what is palliative care? Which is actually my slide number 2. Tell me, you know, I know that many of you on this call were probably on the last webinar with Diane Meyer, the director for the Center to Advance Palliative Care. And I just wanted to start with a basic definition of palliative care. Many of you probably already know this, but it just puts us on some shared ground. So that palliative care is medical care that provides relief from physical symptoms and the stresses of serious illness, especially psychological issues. That palliative care is appropriate at any age and any stage of an illness, particularly cancer, and that especially in the case of oncology, that palliative care is provided along with curative treatment as an added layer of support. And you know, in the oncology space, I think of palliative care in 2 levels. One level is palliative care that is delivered by specialists, palliative care consult teams, inpatient or outpatients. But there's another level of palliative care that is part of really good cancer care. That is the palliative care that every oncologist, every nurse, everybody on the cancer care team should be providing. And many people these days are calling that primary palliative care. It's a little bit of a confusing label, but what I think it speaks to is the importance that frontline oncology doctors, nurses, social workers, everybody have some facility with talking to patients about their values and how those values might guide treatments. So if you flip to the next slide, you'll see the image on the left that comes up is a chest x-ray from a patient early in my career. And if you see both pictures on this slide, it spans the entire 35-year duration of my career and what I've learned. So on the left is a chest x-ray from a guy that I took care of when I was a young oncology fellow. He was a surgeon who had chronic myelogenous leukemia. He was in Seattle for a stem cell transplant, and he got CMV pneumonia, which at that time was fatal. And before he got intubated and spent 3 weeks in the intensive care unit before he died, I didn't know enough to ask him, is this the right thing to do? Do you really want to be intubated for an illness that's, fatal for, more than 95% of patients? And he died in the ICU. We all thought we did the best we could, but in retrospect, I'm really not sure that that's what he would have chosen. He was a very thoughtful surgeon who had spent the last part of his career, the last couple of years of his practice doing some things that were very special to him and his family. And I honestly think if we had given him the opportunity, he might have done something different. On the right, you can see a picture of a patient that I recently took care of. This gentleman's name is Kenny. He's the third from the left, obviously a fisherman. He had metastatic pancreas cancer. He came to Seattle for treatment from Idaho. He was on a clinical trial of a new agent. He got some benefit from it for a while. And then when it stopped working, this time I had a different approach. I said, look, what's really important for you now? And he said, you know what? I want to go back and do a little fishing and hang out with my family. And so this is him, within the last month of life, he was able to go and do a little fishing. I don't think he was there for all day, but the fact is his family remembers this trip as a way that they spent family time together with him, even at the very end of his life. And they treasure this memory as a memory of him coming back from being treated in Seattle and being the dad and the fisherman that he always was. And I think that's some of the change that we can make in how we communicate with patients. It turns out that this change, if you look at slide number 4, how do physicians talk about values and goals, it's still far from widespread. You probably all know that the American Society of Clinical Oncology has endorsed palliative care for patients with metastatic disease at an early level, because there is a now preponderance of data that shows that patients who receive early palliative care have better symptom control, they have fewer mood disorders, they actually live longer. And because of that, ASCO has said early palliative care ought to be mandatory. And this is the reason, is because oncologists in particular still are learning to do this shift into a patient-centered approach, especially as you get to the last phase of life. The next slide, what words do physicians actually use, shows you some words that we have documented now over a 20-year period in audio recordings of physicians talking to patients with a serious illness. Quote, do you want us to do CPR? I mean, pump on your chest like you might have seen on TV if your heart stops. And of course, what this leads to is, patients who say, doc, I want you to do everything, not realizing exactly the implications of this. You know, physicians know that they should be doing this a little differently. If you look at the next slide, it shows you some of the current data about the disconnect between what physicians think is important and what actually happens now. This was a large national survey of 736 physicians done in February 2016. It included mostly internists and subspecialists, including oncologists. Of these physicians, 99% of them said that talking about goals of care and advanced care planning was important or really important. 75% of them said this is my responsibility. They weren't saying just call palliative care. But when it came to how many of them had a conversation, documented it, and billed Medicare, it was only 14%. So there's clearly a huge gap between what physicians know they should do and what actually happens. I mean, part of it is because of this reason. You know, they bring it up and patients look at them, you know, like the woman in this photograph saying, what are you talking about? Are you giving up on me? And because of this, in the next slide, you know, there are a number of reasons that physicians don't try. You know, 2/3 of them say that they don't have time because they're not sure how to handle that reaction. 60% of them say they're not sure the time is right because they're worried they will upset a patient. 46% of them are unsure how to put this to a patient. They're unsure what to say. And what that all overall adds up to is that they just don't have formal training. You know, if you asked a medical oncologist how many of them were unsure about what to say if they were talking about adjuvant chemotherapy for colon cancer, I mean, it certainly wouldn't be 46%, right? I'm going to take this over now. How often do untrained oncologists use skills that are critical to overcoming these barriers that naturally exist when oncologists are talking to patients about advanced care planning or goals of care? Well, in the largest study of oncologists talking to patients with metastatic cancer that's ever been done, oncologists used empathic statements. They commented on patients' emotions in 11% of the conversations. It turns out making an empathic statement is the #1 critical skill to overcoming barriers, because what's happening is patients just naturally have emotional reactions to these conversations. The tendency of oncologists is to try and explain more, and what happens is that patients get more and more upset because they don't feel heard, and eventually, most of the time, oncologists will realize that they should stop, and they just totally back off on the conversation and say, well, gee, I guess I can't talk about it this time. I guess I'll have to come back later. And that's why they say, when they're worried about if this is the right time, that they're not sure the patient is ready. It turns out that if you make empathic statements, you can actually create a moment of understanding. And that is a skill that we teach more than any other in our workshops, because there is data that shows that when physicians and nurses respond to emotion that patients show, when they respond to emotion cues, that's what it's called in the research studies, patients actually retain more information. So this is very counterintuitive, but it's true that when physicians and nurses respond to emotion cues, patients actually retain more of the important information that oncologists and oncology nurses are trying to get across. You know, it turns out physicians, most of the time, because this knowledge has only come out in the past few years, they didn't know that. And so what they deal with are that they are poor judges of their own communication skills. This graph shows a study of internal medicine residents at the University of Washington, right? That we have a highly rated medical resident program, and we ask the physicians to rate their own skills in doing these kinds of conversations, and then we ask their patients, some of their patients, to rate them. And it turns out, as you can see from a scattergram, there is no correlation at all to how they rate themselves and how their patients rate them. You know, if there were perfect correlation, all the dots ought to follow along this yellow line, and of course they don't. They're all over the place. This is part of the situation that we are facing now, that physicians, I think, are starting to realize that they could be more effective, but they think their own communication skills are, quote, pretty good because they've been doing it for a long time. And there's clearly quite a bit of data that shows that experience alone is not a good teacher. Training that they received when they were in training, in their own training program, their fellowship programs, which was mostly lectures and people talking about, quote, the art of medicine, that is ineffective. It's those kinds of education have never been shown to change physician behavior. Physicians trained in that way, they tend to see emotion as a threat, and they wish that patients were just less emotional. And they say, gee, that patient is the problem. And this is widespread in the literature, that physicians faced with a limited skill set tend to blame the patients. And you know, this is a situation that just doesn't get better on its own. There are probably over 2 million patients in the United States who are at risk for encountering this problem, that they are trying to talk about an important moment in their own trajectory of illness, that they get upset because the news is hard to hear by any stretch of the imagination, no matter how compassionately it is delivered, and the physician doesn't know how to handle that, right? And then what happens is that physicians and patients don't have the important following conversations that they need to have about what kind of treatments are really most important. The research, as you guys already know, clearly points out that communication is a learned skill. And I'm not talking about communication about just being pleasant or starting to develop rapport. I'm talking about communication that conveys important information, that responds to strong emotions, that helps patients make decisions at critical moments in their illness. You know, it turns out that if you have skills training that really works, skills training that uses state-of-the-art principles about giving physicians a cognitive map, about showing them a demonstration of what good looks like, of giving them opportunities to practice specific skills, that kind of training changes how physicians work. They use more empathy, they ask more questions to understand, and they explore more of patient values in a very statistically significant way. This skills training is powerful for them, and in randomized trials, when physicians have acquired these kinds of skills, they persist 12 months later, even with very little follow-up or reinforcement. In this trial that was done in the UK, in fact, there was no reinforcement at all. And I think what's happening there is that there is a positive feedback cycle when physicians start to use these skills. Patients respond positively, physicians feel like they're doing the right thing, and so they keep doing it. They also recommend this kind of training to their colleagues in droves. And here's the really critical part: when physicians are more skilled, their patients trust them more. So in a different large randomized trial of oncologists who are trained, you know, when the trained oncologists use more empathic statements, and that PIVA, I realize there's a typo there, that should be P equals 0.024. So the trained oncologists definitely used more empathic statements, and their patients had higher trust scores. And if there's one thing that you need as a physician when you're talking to a patient about changing goals of care, it's patient trust. Yeah, it's the ability to create psychological safety. You know, until very recently, the training that changed physician behavior was accessible in research studies only. It wasn't available to practicing clinicians. And that's one of the things we have been trying to change, because there is high quality evidence-based training that is now ready and being done at scale. Because of our experience training physicians in studies funded by the NIH, we decided to start a 501c3, a nonprofit organization, to make this kind of training accessible widely. And so our organization, Vital Talk, makes communication skills learnable. And we have kind of tracks on our website here for clinicians, faculty who are wanting to become trained the trainers, and institutions who want to change the culture of their institution. We have on our website under the clinician tab a great deal of resources that are starter resources that will give clinicians a taste of what we do, and that's all free. What we charge for is coming to a course. Sorry, somebody's in the background for me. When patients run into clinicians like this, they respond differently. So here, this is a patient with metastatic colon cancer. She was an artist. She's shown here with a picture of her son. Her quality of life was all based on her ability to paint. And the quality of life question that was most helpful for her was, did you get to your painting this week? Similarly, this patient, Taylene, was a music lover. Her big wish getting towards the end of her life was seeing a bunch of music. She flew to Nashville because she wanted to go to the Grand Ole Opry. She went to a Bruce Springsteen concert at a huge stadium near Seattle because she wanted to see him. And that was all part of where she wanted to use her energy. And her treatments got tailored to allow her to do those things. Our courses, and you can see here one of our co-founders, Bob Arnold, teaching a course. These give physicians the ability to talk to a patient actor and practice skills in a setting where it won't hurt a patient if they don't behave perfectly. I think most physicians and nurses put a lot of pressure on themselves because they're perfectionists. It's very tough for them to experiment with new skills when they were with patients, and creating a workshop where they can try it out on their own with a coach, it turns out to be hugely helpful. Here's an example of one of the cognitive maps that we give that we give clinicians for these conversations, because many of them, because they've learned to do this by, quote, feel, they've never had kind of a logic map underneath how they conduct a conversation. And this really helps them know where they are in a conversation. So you can see in this map, which is called REMAP, because we are revising the map of where patients think they're going for late goals of care, we talk to them about making sure that they have given the serious news already. So that's a separate communication task. Then when they're ready to talk about goals of care, they need to reframe the situation so the patient knows that the status quo of just trying another treatment isn't working anymore. They then need to expect emotion and be able to respond to the emotion using a set of skills called NURSE, naming emotion, understanding, respecting emotion, supporting patients, and exploring emotions. Then they need to map out important values that the patient holds by asking questions like, what's most important for you given this situation? Or as you think about the future, what would you like to be spending your time doing? Or who are the people who are in your inner circle, your family or friends, who are part of this, who can support you and who you need to talk to, right? Those are all ways of helping patients put their illness in the context of the life that they have when they're outside of the clinic. The fourth step in this is for the doctor or nurse to align themselves explicitly with the patient and family. Very often physicians, especially physicians, because they're, we're always in a hurry, jump right from the value to here's what you should do. But what we teach is for them to spend a few moments showing the patient that they've heard what the patient is talking about, that they think it's a good idea, that they can use their medical expertise in ways that can help the patient accomplish some of those goals. And so that alignment step it turns out really helpful in making a plan stick. And then we talk about explaining the plan. And a care plan in our minds does not start with code status. It doesn't start with what you're not going to do. It in fact starts with what you are going to do. And so all the things that you're going to do to control symptoms, time treatments, help them explain to family members, deal with anxiety or other mood issues, those should come first. And then when you're done with that, then you can say, you've heard about my top priorities, and here's some things we're not going to be doing. This is a way of making a recommendation to a patient that does not force them to choose not to do something else, because many patients with advanced cancer really are in such a mindset that they've got to try everything and do everything, that giving them a choice is tantamount to always inviting them to go to the last possible moment, and then getting into that and realizing that that might have not been the best thing. We've condensed these tips in a number of ways. I told you about our website already. This is our free app that is on both the Apple Store and the Google Play Store that summarizes a whole series of tips for clinicians to have so that they can consult this, remind themselves about best practices, and receive a daily tip just in time. And that is at tips.vitaltalk.org if you're looking for it. And then there's the face-to-face courses we do with faculty that are located all over the country and actually growing month by month. These faculty are empowered to give workshops locally so that clinicians don't have to travel. We also make arrangements with cancer centers, hospitals, and health systems to roll out waves of training within a system, sometimes by training clinicians within that system to be faculty so that they can do workshops in a sustainable way. And we have a number of examples where that has led to a real culture change within an organization. That's important because with the epidemic of burnout that we are seeing now, it turns out that more communication skills correlate with less burnout. This is a non-randomized study from the Cleveland Clinic that has embarked on a very large commitment to train every clinician in communication skills. And what they have seen is that as their HCAP scores have gone up, their burnout scores for their physicians have gone down. And it's a very important thing to consider in the current climate of medical care. So, you know, I mentioned there are a huge number of patients at risk, that the training exists and it works, and that we are scaling it up. You know, here's Kenny again. The other thing that he wanted to do besides fish was hang out with his grandson, and this is what he did in the last month of his life. And I think it's a lesson for us in how we can both give people the most up-to-date cancer treatments that are technically sophisticated, are linked to the evidence, and that give patients access to clinical trials, and we can also help them do the other things in their life that they need to do. I do not think these things are mutually exclusive. I actually think the vast majority of oncologists and nurses would love to be able to practice like this, and they just need more tools to help them do this. So I am going to finish there and give my presentation back to Peterson and give you all a chance to ask some questions.
Thank you very much, Tony. Outstanding presentation, as always. And we will be pleased to moderate your questions. So please feel free to type in your questions in the chat box on the lower right of your screen. And Peterson will help shepherd them up. Tony, perhaps while we're queuing up some questions, you could talk a little bit more about what the experience is like for folks at a live Vital Talk workshop so they can kind of picture the scene.
Sure, you know, that's a great question. Thanks, Rebecca. You know, what happens at a Vital Talk workshop is that we give, and they're mostly for providers, but we've also worked with nurses too. We give them an overview of why getting better communicational skills is important, how they can do it, and what we're going to be asking them to do. We show them a live demonstration of one of the faculty having a short conversation with somebody who's playing a patient, and then we move them into small groups where they all work with a trained facilitator and where they all have a chance to have a little bit of a part of a conversation with an actor who's playing a patient. And the difference between doing this with an actor and doing this with a real patient is that with an actor, you can start and stop, you can get ideas from your colleagues, you can identify common places you get stuck, you can start to think really explicitly about the communication skills that you need for different situations. And this experience of going to a place where you got stuck and then being able to get through it with some success, that is the moment that changes physicians and nurses. because that experience of being able to be successful where they have previously only been able to back off, that is the game changer in clinician-patient communication.
Thanks, Dr. Bach. And I should start by saying that technology sometimes has a mind of its own. We understand that we got stuck at the beginning on the same slide showing the poll, and we did record the presentation. And so it should be all right. When we send that out, we'll make the edits so you can see the rest of it, and we'll send you a PDF of it. So I'm going to, there's another question, Dr. Bach, and the question is, how does this apply to people who don't have metastatic disease?
Great. So this work applies to people who don't have metastatic disease because patients who are starting any kind of anti-cancer treatment, they are facing what for many of them is a really daunting prospect of having treatments that will have serious side effects and having to figure out how do they adjust their life to the treatments that are going to benefit them. And I think what can be really useful there is helping patients know their values so that they have them at hand when the side effects get tough, and that you as a oncologist or oncology nurse can help make sure that those values get paid attention to when there are choices about treatments, schedules, medications to manage the side effects. And so I think all the same issues come up because it's not that many patients that want to be alive at any cost. The vast majority of patients, when you look at studies, say, you know what, there is a point at which my quality of life really matters. And I think having that kind of conversation with a patient who doesn't have metastatic disease will actually enable you to get them through their treatment with curative intent in better shape, you know, that they've still feel like themselves, that they've been able to continue to do the important things that they want to do and need to do, and that they have really prioritized the treatment that you think is the best treatment for them. And then later, if one of those patients relapses, they will be accustomed to having discussions about how their values interact with their treatments and how you as an oncologist take them into consideration.
Thank you. If you don't mind, could you give us some examples of primary palliative care and how that helps people who have serious but not terminal disease?
Oh, sure. So, for example, a 55-year-old guy that I took care of with stage 3 colon cancer needed to have adjuvant therapy. Was getting Folfox, was terrified because of the possibility of neuropathy, because he was a musician and, you know, he lived by using his hands, and he thought if he lost feeling in his hands that basically his career in life would be over. And knowing that gave me a way to make sure that we paid very close attention to his neuropathy, that I wasn't just doing you know, the usual neurologic exam with him, but that I was asking him how his practicing and performance were going every visit, and reassuring him that if he was at a point where he was really starting to lose significant function, that I would be willing to come up with another plan about his adjuvant therapy that would enable him to continue being a musician. With that reassurance, he was able to go ahead and, you know, get his therapy and make sure that he got all the treatments that could help minimize the neuropathy that he was subject to. And I think the thing that stood out for me was he had come to me from another physician who simply said, you know, it won't be a problem. And what the patient had concluded from talking to other people on the internet was that it was a problem and the other oncologist wasn't taking him seriously. And so he had come prepared to skip his adjuvant therapy because he was worried about the side effects. So, there's a way that you can work with people to make sure that they get the best possible treatment and protect the things in their lives that make their lives worth living.
Thank you. And how do you address cultural concerns in your training?
Yeah, it turns out we do have patient actors who are from some different backgrounds and different ethnicities. It turns out that a lot of the cultural issues boil down to who is going to make the decisions and how explicit do people want to be about the information. So it turns out the issue about explicitness and not talking about information is really best addressed by asking the patient with the family member present, how much information and how would you like to have it? Because actually having a doctor broker that directly instead of trying to make assumptions or guesses about how patients want to have information, that it turns out is the most practical, useful thing as a oncologist. The second part of it is about who makes decisions is, the other place where physicians really get stuck is when patients want to give decision-making authority to someone else, a son, a daughter, or something like that. And I think the thing there is to really broker that decision and make sure that the physician knows what the operating rules are going to be. Of course, it's rarely possible for someone to not be involved with the decision making at all. And I think part of this then becomes for the physician to set reasonable expectations with the patient and the family member about, what's going to happen in the future, showing at the same time that they will respect the patient and family's decisions about how they want to handle something important like information. There are lots of other tiny and subtle cultural issues that come up, and I've only mentioned a couple of them. I don't mean this to say that cultural considerations are not important, but there really is a level of basic communication work that is really all about how do we deal with the technology of cancer treatments. That, in a way, I think is the foundational piece of work. And then some of the other cultural considerations come up on top of that, and I think are something that we will give clinicians the tools to discover so that they don't have to take a whole separate course just about culture.
Thanks again. Curious to know if there's anything being done to incorporate this kind of skills training into medical school.
It is certainly starting to happen that this kind of training is being incorporated into medical training at a couple of different levels. It turns out that, second year students, med students who are just learning to take a history and physical, it's too much for them to learn how to tell a patient they have cancer, to tell a real patient, right? They need to start to get comfortable with taking a history and physical, dealing with lower levels of bad news. So for example, in our medical school, the kind of bad news that we teach second year students to give is, your CT scan is going to get delayed. You're not going to get discharged today. It's stuff like that. It's giving them a small version of bad news so that they start to build the skills and will be ready later for the big bad news. I think there are many aspects of these conversations that are really specific to a particular disease. And over the years, we have come to see that oncologists, as they finish their specialty training, really need to integrate their knowledge about the oncologic treatments with the communication skills that they will need to manage them. And so I think part of it ought to start earlier, and it is starting earlier, but part of it is always going to need to happen as people really become oncologists.
Thank you very much, Tony. We don't have any more questions in the queue, so I would like to close with a question for all the folks who are busy in their day. And I know you probably get this one a lot, but if I were to do something differently tomorrow to start, what would you recommend would be that first next step?
Oh yeah, I think I could recommend 2 next steps, and I'll give 2 because some of them, the first one, many of our listeners may be doing already. And I think going into your visit to say, what are you hoping we'll talk about today as a way of helping incorporate the patient's agenda into your agenda? I think that's one thing. And the second thing is, when you notice a patient has stopped talking or is looking away or might be looking upset, could you, instead of pushing through the next topic, pause for a moment and say, you know what, could you tell me what you're thinking about? It looks like you're thinking about something. That's a way of starting to uncover and normalize patient emotions during the visit. And I think you'll be gratified about what people will tell you. Because when we as clinicians inquire with an open stance about these things, it's tremendously useful in terms of the information that people give us that helps us do a better job with their care.
Thank you very much. Peterson, do we have any more questions in the queue, or have we covered them all?
I think we covered. We still have people on, but I think we've covered everything.
We want to thank you so much, Dr. Tony Bach, and encourage folks to check out the vitaltalk.org website to learn more and follow up. We will look forward to you all tuning in again when we circulate information about September's webinar with Judy Pace and Bob Twillman on pain management, prescribing, and the policy implications. In the meantime, we just can't thank you enough, Dr. Tony Bach, for your wonderful time today and the expertise that you've shared. Thank you all for participating, and we'll look forward to next time.